So here is the summary of tricuspid valve disease. The most common pathology of the tricuspid valve that you will find is tricuspid regurgitation. So TR is common, at least mild to trivial TR, but you will also find 16% of patients who have moderate to severe TR. The most common cause of TR is annular dilatation, so secondary tricuspid regurgitation. Primary causes of tricuspid regurgitation include rheumatic heart disease. The tricuspid valve is the third most common valve which is affected by rheumatic heart disease. Pacemaker leads. Many patients develop tricuspid regurgitation after pacemaker implantation. Endocarditis, especially in drug addicts and immune-suppressed patients. Trauma. The tricuspid valve is the valve which is most frequently affected by blunt chest trauma. Carcinoid heart disease, where we have endocardial fibrosis caused by high levels of vasoactive substances such as serotonin. And congenital malformations of the tricuspid valve, mainly dysplasia and morbus Epstein. Echocardiography is used to evaluate the etiology, mechanism, and severity of TR. To quantify the severity, we use the color Doppler signal, the jet, where we look at the proximal portions of the jet, the flow convergence zone, and the vena contracta. In addition, we use indirect signs of tricuspid regurgitation, such as indications for right ventricular volume overload, retrograde flow into the hepatic veins, and a dilated right atrium and vena cava inferior. Tricuspid regurgitation is a progressive disease with a poor prognosis, especially in the setting of pulmonary hypertension and a reduction in right ventricular function. Thus, we have to be fairly liberal with the indication to surgery if tricuspid regurgitation is present and if cardiac surgery for other reasons is performed. If at least moderate tricuspid regurgitation is present, annuloplasty, in other words repair of the tricuspid valve, should be performed. Now let's turn to tricuspid stenosis. Tricuspid stenosis is usually associated with rheumatic heart disease, and the quantification is very similar to mitral stenosis. We use the maximal and the mean gradients and the pressure half-time method.